Good evening, everyone, and welcome to tonight's Open Hand Therapy Initiative webinar, which is brought to you in association with the University of the Witwatersrand and the South African Society of Hand Therapists. So our topic for tonight is dealing with the drop, hand therapy for radial nerve injuries, and we're going to be hearing from Tammy Williams. So as usual, there will be a presentation, and then after that, we will have a time for questions and discussion. So please put all your questions in the chat box, and then we will ask some of them to Tammy afterwards. If you have any questions about the Open Hand Therapy Initiative or about if you don't get your questionnaire or your CPD points or anything like that, then you're always welcome to contact us on admin@openhandtherapy.org, and then we will get back to you. But for now, it's time to start our presentation. So I'm going to introduce you to our speaker for this evening. Tammy Williams obtained her occupational therapy degree from the University of Cape Town in the year 2000. She started in hand therapy immediately after graduating, gaining many years of valuable experience working in private hand therapy practices in Cape Town. In addition to this, she spent time in Uganda working as a program manager for a humanitarian NGO serving war-affected children. She also spent 2 years in Ethiopia with the Leprosy Mission International, where she worked with local occupational and physiotherapists, as well as contributing to rehabilitation policy development. She has a passion for hand therapy education and has organized and presented in various hand therapy courses in both high and low resource settings. She currently runs her own private practice in Cape Town, where she treats a wide range of hand injuries and conditions. And we are so grateful to her for taking the time to share with us tonight. So Tammy, over to you.
Here we go. Hi, guys. Really excited to be able to talk to a bunch of people from all around the world. Just checking the specs for this evening, I see we've got a lot of people from South Africa, but also from all over the continent. So that's amazing. Thanks for having me. So let me see if I can share. Right, so I'm going to be talking about radial nerve injuries. And the idea with tonight's course is obviously it's just an hour, so we can't give a extensive everything you ever need to know about a radial nerve injury, but I'm going to try and cover the most sort of common topics that we see and spend quite a bit more time on assessment, because I think that's where we often go a little bit wrong in terms of making decisions for our patients, in being able to motivate them and help them know how they're doing. Because if you can't tell them how they're getting better, then they don't know that they're getting better. So it's, unless it's kind of fairly obvious. So I think we're going to focus quite a bit of time on tonight's session with that. So basically we're going to run through an overview, having a quick run through the anatomy of the radial nerve. We're going to look at neuroanatomy, so just refreshing in terms of the different types of injuries that we're going to have. We're going to have some assessment information, so how to monitor, how to make your decisions in therapy. We're going to be talking a little bit about nerve repair, a little bit about nerve praxia, then we're going to discuss splinting, and then spend some time on ways of grading your exercises particularly in that early phase. So when you're struggling to kind of see really good grasp and release with the radial nerve. So just to remind everybody about the different classifications of nerve injury. So with kind of going from left to right, from the sort of milder to the more serious. So with your neuropraxia, you're looking at reversible conduction blocks, and that obviously depends on acute or chronic situations. So if we've got an acute, fresh injury, it's most likely a reversible block, usually caused by compression. And if we get to it early enough, really good prognosis. That can become something more serious, like an axonotmesis. So that's where the nerve gets interrupted. So the actual axon gets interrupted, often more from a crush injury or from a chronic neuropraxia. And with this, the prognosis is fair because you still have continuity of the nerve cells, and it's just the axon centrally that is gone. So the nerve is intact and it can regrow spontaneously. So then the thing that does not grow back spontaneously is when you have a neurotmesis. So that's where you have a complete disruption of the nerve, which includes both the axon, so that sort of electrical component inside, as well as the sheath. And usually when you've got that kind of injury, you've got surrounding tissue injury as well. So there's lots of scarring, there's possibly other polytrauma stuff going on. And so with the laceration, the prognosis is poor unless you have surgery. So if you have surgery, then depending on your rehab, you can actually do quite well. Right, so just a reminder, radial nerve palsy is all about the wrist drop, and it's essentially an inability to extend the wrist, thumb, and fingers. But don't forget that with high radial nerve injuries, you can have elbow dysfunction as well. So I think often we think that the elbow is all about the biceps, but actually there's quite a lot of radial supplied elbow muscles, as we'll see later on. And the key thing for radial nerve palsy is that it makes a massive impact on grasp and release, as well as reach, because if you can't flex and extend your elbow, then your reach is going to be quite limited as well. And then don't forget that radial nerve has a powerful supination component as well. And so being able to control your arm in space becomes incredibly difficult if you've got a full radial nerve palsy. So just reviewing now the nerve itself. So just a reminder, it comes all the way from brachial plexus. I'm not going to be covering brachial plexus injuries today because I think that is a topic all on its own. But we're going to be talking about the peripheral nerve component. So basically where it's coming from the axilla and then traversing through and around the muscles and bones of the arm. So in terms of the upper arm, so now we're talking specifically humerus level. The muscles that it's supplying is triceps posteriorly, so where it goes around the back, and we've got those branches there that's hitting triceps at the back. We then have anconeus, and by the way, when I'm describing these muscles, this is the exact order of recovery. So should you have, say, for example, a high laceration to the nerve, and so you've got a predictable course of recovery down the nerve in terms of motor return, this is the precise order that things are going to return in. So you've got triceps. You then have anconeus, which is a small little muscle that extends the back of the elbow. You've got brachialis, which is a powerful elbow flexor, brachioradialis, which is a powerful elbow flexor, and ECRL. So ECRL, which is our longest wrist extensor. We're going to talk about this more in detail later, but just to refresh you. And then once we cross the cubital fossa, so we're now in the forearm, the motor component is going to be the posterior interosseous nerve, but there are some sensory branches as well. So there's our little sensory guy going off to the left, and there's the motor branch supplying all the motor muscles. And in order of return, that's going to be your ECRB, supinator, your extensor digitorum communis, so the common digital extensor, then comes ECU, then comes the thumb and finger independent muscles. So we've got APL, we've got extensor digiti minimi, or quinti as it's sometimes known. That's for the fifth finger. The short extensor of the thumb, long extensor of the thumb, and then indices, EIP, or extensor indices. So typical compression points are potentially going to be at the axilla. So think somebody walking on crutches badly and compressing the nerve there. Another key area for injury is going to be with humerus fractures. So that's often going to be either a ruptured nerve or a compression style nerve injury at that stage. And then in the forearm, you've got compression injuries around the lateral epicondyle, and those can be both motor and sensory. So we'll talk about that later as well. So in terms of trauma and lacerations, you can have both compression injuries. You can have, think of tumor excisions in the axilla, which was a recent client that I had. Humerus fractures are going to be your most common causes of injury in the upper limb, usually at humerus level, so mid-shaft humerus level, and especially when there's kind of complex humerus injuries. So open injuries in particular, or where there are iatrogenic injuries from RF complications. A few years ago, I had a gentleman whose radial nerve was actually like screwed into when they were doing the RF plate and the humerus. So things can go wrong at that level. And then don't forget, leaving the actual sort of humerus, the shaft aside, the elbow itself can have traction injuries that can cause damage to the radial nerve. So dislocations, and particularly thinking of the radial head, because as we'll see later, the head of the radius is attached to the posterior interosseous nerve with some fibrous connections. So if that gets displaced, dislocated, fractured, there could be compression or neuropraxia complications with the radial nerve. And then direct blunt trauma. So when somebody gets whacked on the arm or on the extensor compartment of the forearm. So thinking about nerve recovery, we've always got to think about acute and chronic situations. So with a fresh injury, or if the nerve has been injured for quite a long time. With repairs, it's important to note that where you've got complete transection of a nerve and it's busy regrowing, sensory recovery does not happen once 9 months has passed, especially if there's been no end plate stimulation. So if you've had a lot of electrical stimulation involved, that may preserve some of the end plate function, but once 9 months has passed, you're not going to be getting a lot of sensory recovery. Fortunately, in the radial nerve, that's not a huge issue because the sensory function in terms of using your hand is covered by the median and ulnar nerves. Motor recovery is more robust. The muscle fibers are thicker, they bounce back a little bit better, and there's been some studies where muscle recovery has actually happened up to like 20 years after the fact, if it gets muscle. That's a bit longer than I'm used to hearing about, but I had a gentleman with a high radial nerve complete transection, the gent who had the plate catch the radial nerve, and he had 100% full functional recovery, but it took 18 months for that to happen. So after transection and repair, you have a latent period of about 3 weeks where there's no growth. Wallerian degeneration, which causes the axon distal to the lesion to die, and that's basically making space, clearing house for the new nerve to grow. Then you're going to get axonal elongation from the point of the repair, which gradually creeps from proximal to distal. And that rate, as we know, normally takes 1 to 3 millimeters a day. And when it's more proximal, the rate of nerve recovery is a bit quicker. When it's more distal, rate of nerve recovery is a bit slower, closer to the 1 mil a day. And then once the nerve gets to where it's going, you then have a period of maturation, which is where the target skin or muscle now has to sort of bounce back in terms of sensory retraining or muscle strengthening to get it back to original function. With compression injuries, the compression can happen at different sites. So usually if you're getting a complete neuropraxia, it's going to be quite high, so at that axillary level. And then you might have heard of the term Saturday night palsy. That's usually when somebody gets a little bit intoxicated and falls asleep with their arm over a chair, and that compression of the chair or whatever their arm is hanging on then compresses the nerve. So it's a bit of a rough way to wake up the next morning. In addition, at upper arm, so usually humerus level, you could get bad sleep patterns. So when people take medication for sleeping or they're intoxicated, if their system or central nervous system is depressed by poor sleep, bad medication, or medication, sleep medication, or being intoxicated, your brain doesn't pick up those protective nerve responses where it kind of tells you to move in the middle of the night. So what can happen is that you can be lying on your arm, not necessarily over a chair, but just lying on it. And then because you're not moving, that compression then gets a little bit more set in and you wake up with your wrist drop. At forearm level, you've got different options there. You've got your radial tunnel syndrome, you've got posterior interosseous nerve compression, as well as differential diagnosis with lateral epicondylitis. So all of those things are happening in the same location. So you've got to be quite clear on what is causing what. So I'll get onto it a little bit more later, but the sensory branch of the radial nerve is the only sensory part that's kind of clinically challenging, and I'll get onto that as well. So that's in the hand. Right, so when we talk about that radial tunnel and the posterior interosseous nerve, so just to orientate you to this image that we've got, we're looking at the anterior part of the elbow. So we've got ulnar over here, we've got the radial head over here. This is supinator, which is attached onto the radius and then goes around the back. So that's causing your supination to happen. And then here comes your radial nerve down from the humerus. And at this level, you're getting a superficial branch heading off to the down to the hand. So that's going to give you your hand sensation, which we'll speak about in a bit. And then here goes the motor branch, which is the posterior interosseous nerve, going underneath supinator. So radial tunnel happens somewhere in this area. It's kind of a theoretical space, so there isn't kind of using the muscles and the various structures here as different landmarks. But your lateral epicondyle is right here. So all of your extensor muscles, your supinator is attaching on there. It's all landing on that spot. So if you've got the tendinopathy on this area, that can be causing inflammation and compression. You can be having ridges of these muscle structures causing compression on the nerve. But essentially, radial tunnel syndrome is classically a pain sensory thing. So it's usually refractory pain going back to the elbow joint itself. It's compressing the superficial branch at this level. Pin palsy is going to be where you're getting compression around mainly the supinator, or where the nerve perforates the supinator lower down. And that is going to be all motor neuropraxia. So that's when you're going to get your finger and thumb extensors not working, plus minus your ECRB, which has differential or different anatomical versions. Sometimes it's on the sensory branch, sometimes it's on the pin nerve itself. Right, so when we're looking at specific motor function, essentially I had a bit of a giggle because the whole open hand therapy initiative is all about opening hands. And I thought, well, radial nerve, if nothing else, is all about opening hands. So your reach, your position in space, your ability to open and close your fingers, that's all radial nerve. So if we go have a little breakdown into what specific parts of functions are being covered, just to help remind you of like what needs to be assessed down the line. So your elbow extension is going to be the triceps, which is very strong, and then the small anconeus muscle, which is a tiny little triangular muscle. It basically is more of a stabilizer to the elbow joint and offers a small amount of extension help. Then when we've got elbow flexion, we have brachialis, which is flexing the elbow with your forearm pronated. So the usual elbow flexor we think about is biceps, but biceps specifically flexes in supination. So brachialis is doing all of the lifting with pronation, but also brachioradialis is helping the forearm flex or the elbow flex with your forearm in neutral. This neutral sort of function of the brachioradialis also helps with centralizing your pronator and supinator. So it's trying to bring everything back into the midline, back into neutral. With wrist extension, the radial nerve supply is ECRL, which is your longer muscle. It attaches at the supracondylar ridge on the humerus, so basically above the elbow joint, and it inserts on the second metacarpal. So it's quite a diagonal course across the forearm. So that diagonal course also means that it is the primary radially deviator. And then remember, this is the one that gets innervated first. So when you are seeing early recovery, you're going to see quite a radial swing to the wrist extension. Your ECRB is shorter, so that's attaching on the lateral epicondyle and is more central because it inserts on the third metacarpal. So you're getting it's a very strong muscle and it's a more midline extensor. So as soon as it comes online, it helps to balance the wrist extension a little bit more, so less of a radial swing. And then the final balancer is going to be your ECU, which balances the wrist by adding ulnar support to the wrist. So it also helps obviously with ulnar deviation. And then getting further down the hand, when we get to forearm rotation, as I mentioned, supinator is the primary supination function that radial nerve supplies, but you've also got this brachioradialis function, which helps to centralize from pronation to neutral and from supination also to neutral. In terms of finger extension, you're going to have your extensor digitorum communis, which is specifically extending the fingers at MP joint level. So that is, so not to be confused with lumbrical function, which I'll go through later. And then you've got your isolated tendon to the fifth finger, that's lifting that in isolation. And you've got your isolated tendon to the index finger, which is also radial nerve. And then finally, we've got the thumb, which is going to be EPL, extending the IP joint, as well as providing retropulsion. EPB, which lifts the thumb base, and essentially CMC joint extension. And APL, which is giving you a diagonal abduction and extension. Okay, so it's a lot of words, a lot of things, but I just wanted to have that down. So you're going to get handouts later with all of these slides on. So just as a quick reference, you've then got those to be able to double check when you're thinking about assessing what the radial nerve is supplying. Right, so in terms of sensory function, this Wartenberg area that we've got over here is your superficial branch, and it's the troublemaker with radial nerve. So in terms of the upper arm issues, we've got 3 different cutaneous nerves, which are all coming out at humerus level. And so any sensory or any high radial nerve injuries are going to give you these patches of cutaneous sensation on the posterior and lateral aspects of the arm and forearm. But the key one is this red zone, the superficial branch. And as I remember, that branch comes off at this level. So although we're seeing the injury or problems here, it has a definite compression point at this level with radial tunnel compression, and then at its exit point lower down where it comes out past the brachioradialis. So if we go now to that sensory branch causing problems, this is the superficial branch of the radial nerve. It exits at brachioradialis here on the side, and it's very vulnerable to compression anywhere from that point to the wrist. So if you think about it, you've got the radius right underneath there. There's not a lot of padding. And so any direct hits to this area, other issues, like think tight watches or jewelry, cuffs of clothing, straps of gaming gloves, gym wraps, anything that's giving like tight compression around this area can then give you pain, numbness, or hyperesthesia in that zone. Of our relevance, don't forget how our splints, casts, or dressings can also cause neuropraxia at this level. Just going back there, I came across this term Nintendo numbness while I was pulling up the data, and apparently this, I'm not a gamer myself, but with the advent of all sorts of additional equipment, VR, gloves, and different gaming straps and things, there's been an increase of paresthesias and this Wartenberg syndrome with the gaming community. So in terms of our therapy goals, there's a couple of just topics that we can kind of have a look at. We always wanting to educate our patients. So thinking of everything I've just discussed, whether it's nerve recovery times, course of the nerves, what's supplying what, explaining to people how their nerve is going to recover, how to exercise correctly, and what precautions they should observe. Another key thing we want to do early on is look at protecting. So with wrist drop, if your wrist is just hanging, you are prone to get essentially ligament strain in the wrist, which itself can cue up all sorts of other pain problems. So just even without having function of not having the nerve, you can now have additional joint pathology because of that wrist hanging. What can also happen is that if we look at stretching, your flexor compartments can get tight because they're not getting used to their full range, and so they can develop extrinsic tightness or contractures as well. And then you want to be thinking about function. So do we need a splint, static, dynamic, low profile, outrigger, whatever your choices are, that can help improve function? And then taping can be quite helpful as a transitional support. So it's not usually strong enough to fully lift a limb that's not working, but certainly as an assistant for guiding therapy or guiding grading in terms of help while you're working can be very helpful. And then with exercise, you want to always be thinking about what you're doing at different times so that it's appropriate for the level that the patient's at. So there's no point trying to switch on a muscle or trying to exercise a muscle that's not at all innervated, because it's going to be frustrating. You're not going to be successful and you're going to lose the buy-in from the patient. Sometimes you want to use cheats. So at this point, you sometimes want to use cheats because in early recovery, those nerve patterns like tenodesis can be helpful to help practice certain parts of the movement. But as the patient recovers, you then want to unlearn those cheats. So you want to unlearn the tenodesis and then be able to use the muscle once it's ready to go. And then you want to avoid co-contraction. So that's where you are engaging more muscles than you need to get the job done. Ultimately, you want to pull the right string. So when you're exercising, and we'll go through this a little bit more in detail just now, but when you're exercising, you always want to make sure that you are activating the group that you're trying to activate and practice. Otherwise, it doesn't get stronger. And then the main theme that I just want to reinforce is that throughout any of those points, you want to be assessing and adjusting based on what is happening with the nerve recovery. So with a full nerve laceration and repair, you're going to get a very predictable return of function because you know where the level of the injury was, and then you know the sequence of the recovery of those muscles, as you can refer back to at the beginning, and you can follow that return of function and pretty much know what's coming up next and what you need to be assessing for. But with a neuropraxia, you can get a very mixed picture. So sometimes the nerve generally is weak and all comes back simultaneously with motor supply. Sometimes you'll get really patchy, unpredictable return. So for example, your thumb and index finger muscles are kind of last on the list for sort of getting sensory motor recovery from a top-down proximal to distal pathway. But with neuropraxia, sometimes that comes back first before the wrist is coming back. So you need to be able to monitor and check because you might have to adjust your splints or adjust your exercises based on what you're seeing in that particular patient. So assessment is always going to guide our treatment. And I'm going to start that assessment by just sharing a video. You will have this link so you can watch the video in its entirety. We're going to just watch a clip So let's see if I can get this.
By the radial nerve is the extensor indicis and the extensor pollicis longus muscle, which extends the thumb and the index finger. And a very quick way to actually examine the radial nerve, regardless of where the pathology is, to see that it's working, is to actually ask the patient to put their hand flat on the table and ask them to retropulse their thumb. So lift up the thumb from flat position on the table. And you cannot do this unless your radial nerve is working and your extensor pollicis longus tendon is working. So if they can do that, you know the radial nerve is fine. And you can palpate that extensor pollicis longus tendon there when they retropulse the thumb. Okay, after doing that, what you're going to do is test the extensor indicis. So tell them to make a fist and straighten your finger out. Now, extensor indicis gives you independent extension of your index finger. You can't do this or this with your extensor digiti minimi without the extensor indicis tendon, as the extensor digitorum communis tendon is a common tendon and you can't do that without. So for example, you can't completely straighten your middle finger or your ring finger without straightening the other fingers as well. Okay? After doing that, you want to examine your extensor digitorum communis muscles. Now, people do this often the wrong way because they're looking for extension, or they ask people to resist extension that way, or they're asking the patient to extend their fingers. Now, there's very fine nuances to this where you need to not be caught out. So the first thing is that if you see a patient extending fingers like this, they're not using their extensor tendons for this. They're using their intrinsics, because what your extensor digitorum communis tendon does, it's an extrinsic extensor of your fingers. What it does is it actually extends at the MCP joints here, not at these joints here. Okay, so if you want to test the extensor tendons, like the extensor digitorum communis, you need to ask the patient to flex and resist extension over the proximal phalanx so that you can actually test extension at the metacarpophalangeal joints. And that's what the extensor tendon does. So get it to hyperextend at the metacarpophalangeal joints. That's your extensor digitorum communis tendon. Just doing that doesn't mean the tendons are working or the radial nerve's working. And other people can cheat by using tenodesis. So make sure they're not doing that. Because if you flex your wrist, your fingers will extend if your tendons are intact, regardless of whether or not your nerve is working. Okay, so make sure the wrist is slightly extended, and then ask them to extend at the metacarpophalangeal joint. You can ask them to hyperextend their fingers as well. They can't do that without the tendons and the nerve working. After doing that, you've examined that, the next thing you want to examine are the wrist extensors. So the wrist extensors are the extensor carpi radialis longus and brevis and the extensor carpi ulnaris. The next muscle to be innervated is the extensor carpi ulnaris, as this is innervated at the same time as the extensor digitorum communis is. So with the extensor carpi ulnaris, you want to ask them to extend their wrist, and if there's any radial deviation of the wrist extension, then you know the extensor carpi ulnaris is not working. And then once the extensor carpi ulnaris is working, it will centralize a little bit there. So when you ask them to extend their wrist, palpate the mobile wad here, because this has your brachioradialis, your extensor carpi radialis, and your extensor carpi radialis, brevis and longus, sorry. So palpate that as you ask them to extend, and then palpate the extensor carpi ulnaris here, just beyond the ulnar bone, and that's what your ECU is as well. So extend, palpate there when you extend. After you've done that, you want to examine for the brachioradialis muscle. So brachioradialis is in the mobile wad here, and ask them to flex their elbow while in a neutral position or in a pronated position, and that will avoid them using their biceps tendon to actually flex their elbow. And then examine for triceps. And from a sensory point of view.
Okay. So one of the points, so you're going to have this, you've got that YouTube link, so you can watch it from beginning to end. It was just going to be a little bit long to do the whole thing today. But one of the things that we find with those kind of assessments is that everything that he was showing us on that video is grade 3. So most of the assessment videos you'll see people are showing you how to check the wrist extensor, how to check the fingers, how to check the thumb, but they're only showing you a grade 3 on or off. Is it there? Is it not there? And I think one of the challenges with nerve recovery is that a nerve doesn't go from grade 0 to grade 3 instantly. And so just to remind us about the different levels, you've got 0, which is no contraction, no return. 1 out of 5, this is the Oxford scale. 1 out of 5 is going to give you a little flicker of movement. So it's an activation, but there's no actual change of motion in the finger. Grade 2 is going to be your active movement with gravity eliminated. And then everything he was showing us on the video was showing you an active grade 3. So that's being able to do the movement against gravity through full range. And then in terms of getting increasing functional return, grade 4 is with resistance at that full range, and grade 5 would be full power, full return. So our challenge as therapists is to kind of really be quite careful with this grade 0 to 3 monitoring, because that's going to help us assess what type of lesion are we dealing with. So is it actually a complete neuropraxia, or is something starting to come back already? It's going to help us track recovery of the patient. So this is super helpful in terms of keeping the patient motivated, because these injuries, especially if you think about high muscle nerve injury, radial nerve injuries, it can take months, maybe longer than a year, for that recovery to happen. And so for people to be able to accurately know that they're progressing, like, oh, I was a 0 last week time we saw each other, but now 2 weeks later or 3 weeks later, it's now I've gone to a 1 or a 2. And so being able to see what new muscles are kind of popping up online is incredibly helpful. But also it's helping to grade your exercise program and make decisions for splinting. So you would not want to, for example, give a person with a recovering neuropraxia, say grade 2, you wouldn't want to give them a full dynamic splint, because that neuropraxia is already resolving. They're probably not going to need it next week if the muscle function continues to improve. So yeah, you want to make sure that you are testing correctly so you know what's actually there, and then being able to make decisions. So specifically when you are testing weak muscles, you have to know what you're testing. So I would suggest going back, watching that video again, and then later I've got a whole sort of bunch of muscle assessment pictures that are going to help you be able to isolate and test everything one by one, so that you're really testing what you're trying to test and not getting sort of overflow pictures of different muscles trying to help out and do cheat movements. You want to first always test in gravity eliminated planes. So when we're talking about weak muscles, I'm now trying to sniff out that, is the 0 really a 0, or is there a 1, is there a 2? But you have to test that in gravity eliminated, otherwise you won't be able to see or feel that return. You always have to give proximal support. So if you've got a very weak muscle, it cannot lift itself and everything else. It can only, with that early muscle function, be able to lift itself. So you need to be able to give proximal support, but you also need to be able to eliminate distal weight of the segment. So for example, if you are trying to, I'm going to unshare my screen for a second just to explain that. So for example, when you are testing wrist extension, you're not going to have your fingers trying to open while you're trying to test your wrist extension. You'll get rid of the fingers as a sort of functional weight there, and then be testing the wrist. And likewise, if you are testing to see are the fingers starting to come back. You're not going to do it with the whole finger in extension because that's quite a lot of weight for the finger to now lift. So you would always do your initial testing with, say, for example, your wrist really well supported, and then the easiest way for that tendon to work, which would be short lever rather than long lever. We'll go into that in more detail, but that's what I mean by block or support proximally to allow that support or to allow that movement, but also then eliminate the additional weight when you're testing. So that also might mean, say, for example, an active assisted test. So where instead of just letting the thumb try and lift itself, you're going to just gently actively assist and see that you're moving synchronously with the person, and you can feel that muscle is trying to work, but you are taking the weight of the limb. So I would always start with your place and hold in a very easy position. So you're going to want to check the course of the nerve, and it'll be clear in the next pictures as well, but make sure you're not testing it in an awkward position where that muscle is at a mechanical disadvantage. And then be very aware of your co-contraction. So that's where the patient's really trying to show you as much as they can, and they're going to be activating unnecessary muscles to try and recruit the one that they're testing. So here's some examples. So if we look at, say, our 0 to 2 wrist extension, we're going to start on the left, trying to just feel for that flicker of motion. So in this picture, I'm supporting the weight of the hand. We're in gravity eliminated plane, and I have my right hand, so over here I've got my right hand with a finger on both of the wrist extensors. So we've got my index finger is on the second and third metacarpals, sort of feeling for that tendon of the radial extensors. And you can't see it, but my third finger is on the other side, on trying to pick up the ECU tendon over ulnar styloid. So we've got radial styloid, ulnar styloid. I'm feeling for those tendons to engage. And so you won't, with this, if you're trying to decide whether it's a 1 or a 0, so you always start relaxed. So I make sure that that person is not engaging any muscles. So I am passively holding that hand in position. And then I ask them to try and lift the wrist. So I will sometimes pattern that movement. So I'll show them what movement direction. So I'll go from neutral to extension, but I'm passively showing them just so that they know what they're trying to do. And then you feeling for any kind of flicker or engagement of those tendons. If you feel anything, but you see no movement, it's a 1. If that person can hold the position, then it's going to be a 1 or a 2. So if it's a really flimsy hold, it might be like a 1, 1 plus. So here, this is here where they're trying to now hold that position. I'm giving a little bit of support there because they may not be able to sustain the full weight of the hand, but I'm wanting to see, is that flicker that I felt over there translating to a little bit of movement? If they can actually hold it in position, now we've got a 2. Okay, so that's over here in that position. And if they can move through range, so gravity is eliminated, and they're moving from flexion or from neutral into extension, you've now got a proper 2 as per the textbook. Right, 0 to 2 with finger extension, I would always start your easy position to activate is, again, we're gravity eliminated. I'm stabilizing the wrist to make sure they're not trying to do that. We're not worrying about the thumb. Thumb's just hanging off to the side. I've got them in that place and hold extension position, and my fingers are on the backs of all of their EDC tendons over there. So they're not having to independently get their hand into position. I'm doing everything. And again, start from a totally relaxed position, and then you ask them to try and hold that position, and you're trying to feel if those EDC tendons are engaging. If there's nothing, it's a 0. If you can feel something twitching, but there's no actual lift of the finger, it'll be a 1. And then I find that it's quite hard for someone to go from that position to then just be able to hold a long lever extension. So it's basically going from like a 1 to a 2 or 2 plus. So I will often test the EDC with a short lever position because I find that that's a little bit easier for them to hold. So we're still in gravity eliminated. Same principle, I've put them into position. MPs are now extended. They don't have to worry about trying to lift the tips of their fingers. They're only concentrating on extending the MP joints. And so if they can hold that very flimsily, it will probably be considered a 1. If they can hold it a little bit more stably, it'll be more of a 2, like here. And then if they can do that flexion to extension through range, then it's a solid 2 because we're in gravity eliminated. So if we, in an alternate testing position, is with, now we've got kind of with gravity, but I'm going to still consider testing with short lever. So I'm supporting the wrist over here. I'm supporting the full weight of the fingers in extension over here. So again, we're still in that, it's a totally passively held position that I'm doing. And then I ask them to engage. If they can engage that extensor tendon, which I'm feeling for over here, as well as seeing are they able to sort of lift off my finger, then I know it's not lumbrical extension because these fingers are not, the PIPs are not extended. And so we're checking, is it a 1 or a 2? A 1 is going to be where I can feel they're trying to lift off my finger, but they're not quite getting there. A 2 will be if they can sort of hold it a little bit more clearly. I struggle to know whether to grade this as an actual 2 because in a gravity position, if they're able to hold it or move through range, it would be a solid 3. But this is a short lever position, so it's not a full finger extension, which would be PIP joints extended as well. But then if they can go through range, you're now going from a 2 to a 3. So these are just some alternate ways of checking for flickers of movement, checking for active engagement of those tendons. So essentially for independent finger extension, you've got this is going to be pretty much the same for the 5th finger as well as the index finger. Place and hold gravity eliminated. You're going to let them then hold their finger themselves. That's going to be a 2. And can they move through range? Also a 2. So all of these are sort of less than the 3s that you're going to see with gravity in place. And then for the thumb, I'm giving full support to the wrist and the thumb, and we're checking to see, am I feeling any flicker of engagement of that EPL? Can they hold it in place? Can they do the lifting from flexion into extension? And then that's going to be a 2. So you're going literally from a 0, any engagement, placing hold, move through range. For EPB, that's more at the base of the thumb. So here I'm passively holding that in place. Again, I'm checking the tendon to see can they engage. So you're feeling for a flicker or no flicker. Then for a 1 to 2, sorry, my hand should not be there. Hold that position, or can you feel like they're lifting off your thumb here to get you that 1 to 2? And then just comparing those EPL and the EPB measurements to what a full extension number 3 looks like. You really have to have that EPB tendon engaged and the EPL tendon engaged to be able to do that. Right, so splinting considerations, you always want to just double check about concomitant injuries. So are there other fractures that would be, so say for example a wrist fracture that's going to impact how you splint. Is there flexor weakness? So we're speaking specifically about radial nerve, but are there combined median and ulnar things happening as well, which would influence how you're going to, for example, you can't put a dynamic splint on someone with median nerve palsy because they can't flex properly against it. So they're going to basically get stuck in your dynamic splint and not be able to move. Also consider whether they can understand how to use the splint, if their goals are to be functionally independent, or if they're quite frail. You want to keep it as simple as possible. And then the signs of recovery that you're seeing from your assessment, is that the timeline that you're anticipating that this person's recovering, does it warrant a full dynamic splint, or actually do they just need a little bit of support for a week or two until that's going to return? You also want to just understand your practice and what are the materials and time available to construct a splint. Consider static versus dynamic, and your dynamic can have the whole full scary outriggers, but they can also be quite low profile. So your pros and cons with static orthoses, they're fairly simple to produce, they're easy for the patient to apply, they're a good option for complex injuries where you can't pull against outriggers or pull against elastic bands, and they can be adjusted and trimmed. So for example, you can include the MP joints or exclude the MP joints, and off-the-shelf braces are also possible as a static orthosis. The cons are that you don't get full end range flexion for MP joints if you're blocking in extension, and so that also impacts how you're going to flex. So some examples here, this is a static splint dorsally, where these are not elasticated straps, these are just Velcro loops which are holding the splint in place. So the patient slides their fingers in and then gets strapped on. And there's a step-by-step sort of tutorial on how to make the splint with that link. In terms of dynamic splints, the pros are that full outriggers give you like a great arc of motion, but that also can be quite bulky. They maintain functional use of the hand over a lengthy period of time. So if you know you've got a high median nerve that needs a lot of help, go for that. There are low profile designs available which kind of get rid of the bulky outrigger options. The cons are that sometimes the construction bed can be quite complex, and you can need some skill to make sure that you get all the angles of pull set up correctly. They can potentially be more difficult for the patient to apply, but I think the low profile ones are a bit easier. Bulky outriggers are quite scary, but also functionally can be getting in the way when they're trying to use their hand. I do sometimes find that the low profile options have a limited arc, so the fingers can't pull through a big range of motion with the elastics. And if you've got other flexor weakness, it's going to prohibit your functional use of the splint. Right, so this is some couple of pictures. So we've got these, a couple of sort of short arc, different types of outriggers. You've got metal outriggers, off-the-shelf ones, Orphe tubes that are providing elastic along the line of the hand. So there's a lot of different options that you can go for what's based in your practice. This is an interesting one that I found online, and I've just put the link up there to be able to find it. It's essentially a sort of a splint that allows both wrist extension but radial and ulnar deviation, and then it's got a low profile elastic support to suspend the fingers. And this was a new article from 2023 it's an off-the-shelf brace, but with an insertable outrigger option that gives you quite nice independent elastics for each finger, a little bit bulky in terms of the block of it, but quite nice if you've only got sort of off-the-shelf brace, and it's something that then could be removed. So the patient could wear it during the day and keep their off-the-shelf orthosis on at night. So I'm just going to run through this very quickly. A recent splint case study that I had of a lady with a schwannoma excised from her axilla. So she had a neuropraxia, and the first session I saw her, she had no wrist extension, a little bit tiny flicker of ECU, and minimal, so no thumb recovery, tiny little bit of index finger, tiny bit of base of thumb, but she did have her upper arm was fine. So all her elbow flexors and supinators were okay. And so this is one of my favorite static sort of hybrid splints. It's just a post box extension splint and with a little optional Velcro strap for the thumb. And what we do is put the MP joints in about 30 degrees of extension, and she found it incredibly functional. So you've got no outriggers. You can pretty fully extend, so you get a good wide span, and it's no mess, no fuss. You slip it on with basically one strap. You can just slide your hand in, and that's the pattern. So you're going up to the MP joints. You've got the post box format that your hand slides through at distal palmar crease. And if you were just doing a wrist cock up, you would cut it off there so that you're lifting the wrist. And PIP joints are then giving you that MP joint support if your extensors are not working. So a couple of other modalities to consider. You've got to think of scar management. You've got to think of neuromuscular electrical stimulation, so to keep end plates engaged, and definitely screen for ergonomic compressions. So if you've got neuropraxias, you want to be making sure that they're not repeat irritating that nerve in sleep, at their workplaces, the equipment that they're using, etc. And you can't basically work a muscle if it's not plugged in. So don't try and exercise something that's not yet innervated. Make sure you've got proximal support for distal function, and regularly reassessing to know what has switched on and what can I work. This is an analogy I often use with patients. So just to kind of make sure that grading is really essential with your active exercises. You've got place and hold, you've got your short lever, long lever, as we mentioned before in assessment. You can add gravity, you can add resistance, you can go from simple to complex, but always if you're targeting one isolated group, make sure you're avoiding co-contraction, cheats, fatigue, and making sure that they're actually exercising the thing. I often say to patients to try softer, because when they're trying harder, they end up co-contracting or not recruiting the correct muscles. So just a reminder about those cheat movements. Tenodesis is with that wrist drop. Intrinsic finger extension is when you're not actually lifting at the MP joints. It's just the fingers that are extending through intrinsic and lumbrical function. And then this thumb intrinsic abduction, that's when they actually oppose the thumb instead of trying to actually extend it. So some quick little exercises when you've got a weak sort of a sub-3 muscle scale. So often what I'll do is use a pull noodle for support so that the weight of the hand is supported by the noodle. I'll put a bit of cream on the table, and then they can be able to slide that backwards and forwards in whatever position you want. Using the noodle again, you can position the weight of the hand, and this is almost like an active assisted movement. So when you extend the wrist, the weight of the hand is supported, and you can roll backwards and forwards with a grade 2 muscle and be able to practice lifting the wrist. You can also swing that left to right for radial and ulnar deviation. With a stronger muscle group, you can now actually lift off the table and use a pencil or a pen to lift up and then see the radial and ulnar deviation as you tip that side to side. Things like a wrist wind up help you to sort of practice rolling up and down with or without a weight. And then just general grasp and release activities. Once you're in the +3 range, you can start to add your resistance. For thumb and finger extension, using K-tape to assist a recovering EPL is quite helpful, because you can't usually get an outrigger onto the tip of the finger anyway. So dynamic taping I find very helpful. And this is the lady I had earlier when I made the splint. So this is the second time I saw her when her thumb had started to actually recover, and we added that tape to help it lift. And I've trimmed away here because her index now has full active range. And some little sort of stronger thumb exercises. So you could add an elastic band to help move that. And this is you trying to hop over the bottle to go into more of a retropulsed position. Quick little thing about nerve glides. I'm not going to go into it in detail, but this key issue about extensibility, an uninjured nerve has 20% extensibility relative to its length. An injured nerve, so anything with old scarring, compression, that extensibility reduces down to 8%. So you want to be very careful about gliding and stretching injured nerves. Be slow, be non-irritating, and work with a small arc, so you're just gradually increasing as the nerve allows. Be segmental and don't do too much. Nerve glides, there's 1,000 videos online. They always show you different ways of doing it, so you just have to pick the one that makes sense for your practice. And then finally, while we're waiting, this nerve recovery can be incredibly long and arduous. And so there's a couple of things to just remember generally to keep the nerve healing well. Smoking is really important to stop if possible, because it both decreases the oxygen supply for the blood flow, but it's also neurotoxic for the nerve that's trying to regrow. Vitamin B supplementation, 1, 6, and 12, are the sort of healthy nerve vitamins. They help with regeneration, myelin support, regrowth of nerves. Making sure you're not compressing the site of the nerve lesion. So both with the interventions you're doing, like splints and massage and scar massage, but making sure that the patient's aware of other clothing or things that might be compressing their site. And doing electric stimulation is very helpful for just keeping the nerve firing while you're waiting for the actual supply to get there. Thank you. Sorry for going a bit over time.
Thank you, Tammy. That was really helpful. We are a bit out of time now, but I will ask you just 2 questions quickly before we stop. So there was one question about Wartenberg syndrome versus de Quervain's. Since the primary symptoms both is pain, how do you differentiate between them?
Okay, that's quite easy to differentiate. So the Wartenberg really has that map of pain that is on the hand. So it's a specific patch of pain that's supplied by the radial nerve. And you can definitely have them in combination. So I'd say they're not necessarily an isolated thing, but de Quervain's has more of your Finkelstein test, so that's with movement of the thumb. So movement of the thumb would not affect Wartenberg at all. And if your Finkelstein is when you're holding the thumb, if you're already positive, you're kind of irritating that first dorsal compartment here. And then if you're going to do an ulnar deviation, you're going to pinch that nerve. So it's de Quervain's is more of a mechanical limitation with the first dorsal compartment tendons. Wartenberg's, although they're in a similar area, Wartenberg is purely sensory.
And then one last question. If you're considering a static splint for radial nerve palsy, what would be your reasoning behind using a volar versus a dorsal design?
So you want to try and promote as much volar open as possible. So you want finger, hand, arm in contact as much as you can for functional recovery. So you don't really want to be doing volar designs because your hand is already struggling. If you think of the cortical integration of that limb that's now got nerve damage, you want as much contact and sensory input with the rest of the world as possible. So you'll find most designs online are not volar. So sometimes you'll have a wrist cock up, like say if you've got great finger and thumb function, but you've purely got limited wrist extension, then you might have some cock up designs that are volar. I personally prefer the sort of post box design where you've got a bar in the hand and all of the support is more posterior.
Perfect. Thank you so much.
Mm-hmm.
Okay. So thank you everyone for joining our webinar tonight. You will receive a link to the Zoom recording by the end of the week. And then what I'll do is I'll include the link to access the notes for the presentation in that same email. And then the webinar will be available on YouTube as well. And you can have a look at the YouTube channel to also see a lot of our past webinars there to see if there's anything you missed out on that could be helpful for you or some of the patients that you're seeing now. Okay, then our next webinar is going to be on the 5th of May, and the topic is primary care of hand trauma, general principles for managing acute hand injuries. with Neil Kruger and Peter Jordan. So I think that'll be very interesting. I'm definitely looking forward to that. And then to keep up to date on our webinars, you have some options. You can follow us on Instagram or Facebook. Then you can also check out our YouTube channel, as I mentioned. And then another option is to join our mailing list. So this way you will get the sign-up links delivered directly to your inbox each month, along with some news about how we are doing. Okay, so that brings us to the end of this evening. Thank you again, Tammy, for your lovely presentation. It was very helpful to understand radial nerve injuries a bit better, and I'm sure we'll be able to treat our patients with more confidence after hearing all your explanations. Thank you so much.